Take it away.
Okay, well, let's let everybody introduce themselves. So our discussants are Gurleen and Josh. Is that right? So, Josh, I've heard you say this a million times, but they haven't. So, tell them who you are.
Hey everyone, I'm Josh. I'm an MS4 over here in Austin, Texas, at Albany Medical School. I'm a proud cat dad, so you might see a tail kind of whiff in front of my face here in a few minutes. I'm excited to be part of the discussion. Applying med-peds.
Great. I certainly hope you're applying to UAB. And you too, Drew.
You know it, Uncle Bob. You know it.
Gurleen.
Hi everyone, I'm Gurleen. I'm also a MS4 up in Albany, New York at Albany Medical College, and I'll be applying to IM this year.
Great. And for those people who don't know Sean and Stephen, they're two of our 4 great chief residents. Why don't you just quickly introduce yourselves?
Yeah, I'm Stephen Alon, Birmingham native here doing my chief year at UAB, plans to do academic general internal medicine.
And I'm Sean. I'm not from Alabama, almost exact opposite. I'm from Michigan, but I'm loving it down here. Birmingham has been an absolute delight. If you ever get the chance during a non-pandemic time, please come visit Birmingham. Best kept secret of the South, I would tell you. So with that, I think I can let Stephen take it away.
Wait a second. And you're applying for?
Oh, yeah, I kind of left that out. I was saying a lot about Birmingham. I'm applying for rheumatology. So if you see me, like, my eyes get big, maybe I got an interview invite during this.
And we are going to do some rheumatology ones later on. Okay, so since I'm a Southerner, ladies first.
All right. Well, so Gurleen, I'll just give you a little bit of context and then we'll let you look at the labs and take it away. So this is a 40-ish-year-old gentleman who comes in to the emergency department with shortness of breath for several weeks, who has the labs that you see before you. When you hear that HPI and you see those labs, what are you thinking? I think you're Gurleen.
The first thing that strikes me is the low potassium, the 2.6, as well as the low magnesium and the low phosphorus. I think that's what my first thing that jumps up to me. When I'm looking at all 3 electrolytes, I kind of think about if there's some type of transcellular shift going on that could be causing both low phosphorus as well as low potassium values. Just looking at the history, the shortness of breath, something that just jumps into my mind is like certain drugs like beta agonists like albuterol can cause both shift of potassium inside the cell as well as phosphorus at times. So that's like initially what I'm thinking about. Looking at the bicarb value, I guess it's like a little higher than the normal value of 24, so some type of alkalosis. So I guess the other thing I would like be helpful to know is like albumin or like overall nutrition status, to look at how much of this could be poor intake versus poor absorption versus other things going on. I guess the other thing when I think about low potassium is that whether it's, I guess like the pH, if it's like low potassium along with alkalosis or acidosis or like a normal pH. So I guess with the bicarb being around 28, I'm kind of thinking initially if it's in the normal range, it might be more of a cellular shift. But if there's more suspicion for like acidosis or alkalosis, then I would think more about like GI losses, renal losses, or kind of like look at other things. That's what I'm initially thinking.
Okay, Josh, what do you think?
How long has this shortness of breath been going on again?
Just for a few weeks.
Few weeks, okay. So I don't have too much to add because Gurleen kind of knocked it out of the park on that one. But when I'm in the children's hospital right now, so when I see mag, phos, and potassium all low, I think about a refeeding type syndrome. And especially with the shortness of breath, I start thinking about maybe a respiratory acidosis leading to that high bicarb. And I'm also kind of struck by the low chloride. And so that makes me think, maybe is this going to be a saline responsive metabolic alkalosis going on in the background? But I think there's probably like 2 things going on. And also I'm kind of intrigued by that BUN and creatinine ratio. It's the creatinine seems pretty high for a BUN being that low. So I'd really want to know, like, who is this person and what do they look like, to Gurleen's point about wondering about their nutrition status. And also just like their metabolic, sort of what their metabolic rate is right now and whether that's increased substantially or decreased.
Okay, so what acid-base problem did you miss?
I mean, he's got a gap of 17 as well.
It's got a gap of 17.
I kind of like put on the shelf because I just had no idea what to do with that with the bicarb.
Okay, but that's actually important. So Gurleen wanted an albumin, and one of the reasons we want the albumin is to figure out whether this is a significant anion gap. If this patient really has some malnutrition. So my first thought when I see this is somebody who's been drinking too much, because I see this is what I see at the VA all the time. And if he's been drinking too much and he has a decreased albumin, then that anion gap could really be very important, because we're going to have to adjust our expected anion gap for the albumin. So that albumin is important. It's not as important for nutritional status. I think we overestimate the value of albumin for nutritional status. Your comments about respiratory acidosis with compensation versus metabolic alkalosis are spot on with shortness of breath. And so we do need a pH. Because he's short of breath, I would prefer an arterial blood gas over a venous blood gas, because we want to know what his respiratory status is also. What do you think about this FOS?
I'm a little concerned about it. I can't remember if the really critical level is below 2 or below 1, where we really start getting nervous. And I'm 100% on board with an ABG. I'm in the cardiac ICU right now. So I look at tons of ABGs every day and would love to geek out over some of that data.
So most articles say that the critical value of FOS is less than 1. But why don't we take a sideline and talk about why we worry about phosphorus? Okay, so if the phosphorus gets less than 1, there are 5 systems that put the patient at great risk, including mortality. So let's see if the two of you can come up with those 5, and then I'll teach you how I think about it.
So I guess like when I think about low phosphorus, I think about how phosphorus is important for like ATP generation. So like any like metabolic, like muscle kind of symptoms, like I guess the heart, cardiac symptoms, arrhythmias, like neuromuscular weakness.
Okay, so you're exactly on the right track. That's beautiful. And what I'm going to do is I'm going to help flesh that out for you. Did you have any thoughts on that, Josh?
I'd throw the brain on there, just because the brain seems to be a pretty sensitive organ to everything.
Right.
And then
you're correct. And we don't have Jory May here today, but we're going to have to include the hematological system. So this is the way I think about it. I start out with the brain, and it can cause seizures and it can cause altered mental status, and you can die from those seizures. Then the next one, as Gurleen said, the heart can cause arrhythmias, and that's the common reason that people die of severe hypophosphatemia. And it can also decrease cardiac function. So it can lead to heart failure, because you'll get decreased contractility of the muscle. It can cause respiratory failure because of exactly what you said about the muscles. So we've got brain, we've got heart, we've got respiratory. It can cause rhabdo, exactly what you're saying about the muscles. So therefore you could get rhabdo and acute kidney injury. But the one that most people don't remember is that it also causes both hemolysis and decreased function of white cells. White cells need ATP, and so you don't fight infection as well. So what's the most important thing that these labs would tell you? Let's say this patient came in, is not feeling very well, and they think, well, maybe he's a little volume contracted. What are you not going to give him yet?
Glucose.
Exactly. So giving this guy glucose would be a major, major mistake, because once you give glucose, then you're going to cause the refeeding syndrome. So he's starting out in horrible shape, and we're going to try to treat that phosphate, and the phosphate is the most dangerous thing on here. The potassium at 2.6 we have to fix. The mag we have to replete as mag. But you're right, he's losing all this intracellular stuff. I really want to know what his albumin is and what his blood gas is. And that way we can start to put together the acid-base disorder while we're trying to figure this out. In the meantime, I'm going to be giving him phosphorus. So I'm giving him phosphate, I'm giving him mag, I'm going to start him on potassium supplementation while I'm trying to figure this out. Does that all make sense? Okay, so can you give us an albumin and a blood gas?
Yeah, absolutely. So his albumin was 3.0. And his blood gas, we did get an ABG. His pH was 7.49, PCO2 30, PO2 78, bicarb 27, and that's on 4 liters nasal cannula.
Okay. So what does the albumin of 3 tell us about his anion gap? So do you know how to adjust the expected anion gap for the albumin?
I think the shortcut is like 3 times albumin and then like.
Right, you've heard me say this before.
Yeah.
Yeah, so, and that's close enough. Whether it's 8, 9, or 10 doesn't matter, but it's somewhere in that range. So if we say that it's 9, that means he has an increased anion gap of 8. That's the equivalent of you or me having an anion gap of 20. Now, we probably don't have a very serious anion gap, because anion gaps less than 25 usually are not that serious. But without getting any more history, what fits these numbers? What anion gap fits these numbers? It'd be one of 2.
I kind of wonder about a ketoacidosis, but that wouldn't explain the high bicarb.
Oh, so we'll get to that. But yes, he easily could have, and it'd probably be a starvation ketosis. Although if he turns out to be an alcoholic, then it could be an alcoholic ketoacidosis, right? Or what else could he have? We don't have any vital signs on him yet. Like
an ingestion, like if it was more acute, but I guess here it's more.
I'm not as concerned about an ingestion right now as I am about what?
An RTA maybe?
No, an RTA would give us a normal gap acidosis. Okay. So I'd be worried about some lactic acidosis. I don't want to miss lactic acidosis. Now, what do you think about his blood gas?
It's missing a lactate currently, which
it'd be nice to have a lactate, and my guess is if we asked for it, but let's say we don't have the lactate yet.
It looks like he's hyperventilating a little bit.
Right, and is he hyperventilating more than you would think?
I'm trying to do the math in my head.
Why do you think he's hyperventilating? Okay, so that's why we got an arterial blood gas. Mm-hmm. So if you notice, he has a huge AA gradient. Now, we could do the calculation. If he's on 4 liters and his oxygen is only 78. So he's probably hyperventilating to maintain his oxygen, not to fix an acidosis. Now, I don't remember all the compensation formulas, but my guess is that this guy's got a metabolic alkalosis, an anion gap acidosis, and a respiratory alkalosis. Because a bicarb of 28 should not cause you to hyperventilate. Notice I say hyperventilate. write this one down, Drew. PCO2 is a pure measure of ventilation. When you talk about hyperventilation, a decreased PCO2 is hyperventilation, and increased PCO2 is hypoventilation. There's no other, that was on my internal medicine boards. That question was on my internal medicine boards. And it's important to think about that, which is different than tachypnea. So hyperventilation is not equal to tachypnea. So he has a huge AA gradient. So we're gonna need to look at that. Do we have that lactic acid?
Yeah, we do. It is 7.8.
Okay, so are we surprised by that? So Josh, you're pretty surprised, and you're in the IC right now. So why don't you take this one?
Not necessarily that I'm surprised after your discussion. Just that's a pretty darn high lactic acid.
It is. What does lactic acid mean to you?
So in this one, it seems like he's in a hypermetabolic state right now, or has maybe got a substrate deficiency going on, leading to a lactic acidosis from shunting glycolysis away from.
Okay, so let's think about what causes lactic acidosis. So there's type A, type B, and then weird stuff. Okay, what's type A?
That's hypoxic lactic acidosis.
So yeah, so it's dying tissue that's not getting enough oxygen for whatever reason. Okay, the type Bs are other things that cause lactic acidosis, which could be tumors, or could be drugs, or could be nutritional. Now, what nutritional thing would you automatically think of in a guy who has hypophosphatemia?
Liver disease causing low gluconeogenesis.
Okay, that'd be a possibility, but that's not, you didn't get what I was thinking, but I like what you said.
Alcohol.
Okay, and it's another reason not to give glucose.
Yeah, alcohol.
Alcohol.
Yeah, but alcohol usually doesn't cause a lactic acidosis, it causes a ketoacidosis.
I mean, he could have a ketoacidosis as well.
Right, but if he's an alcoholic, what might we need to give him before we give him glucose besides phosphate?
Diamine.
Yeah, thiamine causes a lactic acidosis. Okay, so in this guy, we have to assume. I still don't know the rest of the story in this guy, but I have to assume that he needs thiamine because of his mag, his phos, and his potassium. And so that may not be the cause of the lactic acidosis. I'm going to have to look to see whether or not I think that it's a type A, but could be a type B. Now, he might be on a medication that causes lactic acidosis. We don't know what meds he's on yet. So we actually need to start getting to know more about him. Is he an alcoholic? Has he had a fever? What kind of lung disease does he have? Because he's got some kind of horrible lung disease. Now, we don't know if that's heart disease or lung disease. Could it be an alcoholic who aspirated? Could be an alcoholic who has TB. It's all kinds of possibilities. And we're getting all this just by looking at his labs. So, let's just do the delta gap, just because even though we've done it before, spaced repetition is always good. Okay, so let's assume that his gap should be 9. So what's the difference between his gap and what his gap should be?
8.
This is math. This is easy math.
8.
8. Okay. So what do we do with that 8?
It's delta gap over delta bicarb.
Okay, so that's the delta.
Mm-hmm.
I've never been able to understand the delta and what the numbers mean. So what I actually do is just, and it turns out Joltoff does the same thing. I just add the 8 back to 28. I assume that gap would all become bicarb, which is an incorrect assumption. So the add back method means that we're really dealing with bicarb of 36. So your original thought about, is this going to be saline responsive or not saline responsive, I'm ready to order what urine test?
Urine chloride.
Exactly. That's always the right answer. So a urine chloride is going to help us understand whether this is a volume problem that's going to be responsive to saline, or is this some kind of an aldosterone or aldosterone-like problem? And that's going to be helpful in terms of management. We're reluctant to give him too much fluid until we understand what his volume status is. But I think it's about time to get more history.
Yeah, absolutely. So he's a 40-ish-year-old gentleman who has had very little medical contact in his life. Aside from shortness of breath, he really doesn't have any other significant symptoms except just fatigue. No fevers, no dysuria, really no other localized infectious signs. As far as his past medical history, because of his minimal medical contact, we don't really know. He says he doesn't carry any diagnoses. And then you would specifically ask about alcohol. He says he drinks maybe 2 or 3 beers a night.
Has he ever been incarcerated?
He has not.
And do we have a sexual history?
Yeah, he's monogamous with his wife of the past 15 years.
Okay. So why did I ask those questions, Gurleen?
I'm not exactly sure.
Okay. Josh, do you have any idea?
I don't know about the sexual history, and for incarceration makes me wonder about either TB or hepatitis, just kind of buzzwords come into mind.
Yeah, I'm concerned about HIV, and could this be, because he's not had medical care, could this be the initial presentation of pneumocystis? And I've seen that before. Now, we don't know what he looks like now yet. We don't have a CBC yet, and we don't have a chest x-ray yet. And we're going to have to get those things because we got to figure out why he has such a huge AA gradient. We could estimate his AA gradient if you really want to. And I think that Drew may have done that before. Did you do that, Drew? I think I saw that in the chat.
Yeah, I think he put about 150.
Yeah, so it's a huge AA gradient. Now, we could have guessed that because even if this was room air, this would be a big AA gradient. Let's go back to that BUN creatinine that you were concerned about. I think Josh was concerned about. The only thing, 10 is not that low for 0.9. And if he was really, really malnourished, if he was a hard drinker, he might have a BUN of 2 or 3. But 10, I'm not going to get excited by 10. So what we have to figure out is why does he have this lactic acid? Why does he have the metabolic alkalosis? We know why he has the anion gap acidosis, and we're pretty sure we know why he has the respiratory alkalosis. Now, we're being theoretical here. If this guy's admitted to you, you'd go ahead and get serum osms and check an osm gap, and you'd go ahead and get a salicylate level. Because a salicylate level could be a cause of respiratory alkalosis. Now, I think we have an alternate explanation here. But we have to assume that this all started in his lungs. Has he noticed that his appetite has changed during this time?
Yeah, he's had poor appetite for the past several months.
And B symptoms, weight loss?
No B symptoms.
So he has a poor appetite, but he hasn't lost weight, but his electrolytes look like crap.
Yes.
Okay, that was technical medical talk.
Is this pre-COVID? Just thinking.
Yes, this was pre-COVID.
Yeah, most of these cases were when Stephen was an intern. He saved them all for us. Okay, so a lot of people did want to see these kinds of questions, so that's all good. So what we might as well examine him.
Yeah. Yeah, so when you examine him, he's in moderate respiratory distress, using accessory muscles, has conversational dyspnea, and he overall does appear wasted. He's got temporal wasting, pretty minimal muscle mass everywhere. Cardiac exam is pretty unremarkable. His lungs do have crackles throughout, no lower extremity edema, and the remainder of the exam is really unremarkable.
So does that help us? Gurleen, does that help you or just reinforce what you were thinking?
I think it kind of just reinforces like the wasting and stuff, that there's some type of chronic process going on. That's something related to the low electrolyte levels over time as well. I don't think it like helps kind of guide us to a specific area, but I think it just kind of reinforces what we were thinking. I feel like we still need like to figure out what's going on in terms of his respiratory cause, like what's driving that process.
Right. So we asked for urine chloride. We probably want to get a CBC. You can make a case for urinalysis just because I like urinalyses, but we don't have to make a good case for urinalysis unless we find something on his chest x-ray, because you always have to think about pulmonary renal syndrome. So whatever's going on in his lungs, the chest x-ray is going to be helpful. If he came into UAB, they sent off an HIV test. So we want to know what the HIV test is. Just because we didn't get the history of high risk behavior doesn't mean sometime in the past 20 years he didn't do something that put him at high risk for HIV. And so you just can never assume that just because of the history that's not true. So can we get some of those things?
Yeah, absolutely. So his CBC shows a white count of 11 with a hemoglobin of 7.8, crit of 22, platelets of 276, and an MCV of 117. We did get a UA, which was completely bland, no ketones, no blood, no white cells. A urine chloride, which was 15. And then, was there anything else, Dr. Centor, that you asked that we're missing?
We'll be getting a chest x-ray in a few minutes. Okay. So this is incredibly fascinating. I get to go to Jory May's where I really need Jory right now. Okay, so let's just do the urine chloride first, since you asked. I think Josh asked for the urine chloride, or did Gurleen? One of you asked for urine chloride.
I think I mentioned it at some point.
Okay, so what do you think of that?
So the urine chloride was 15. So I think if it's less than around 20, that means that it might be like responsive to fluids.
Right.
So it could represent just like I guess like any renal losses, volume contraction, diuretic use, but he's not on any medications.
Right. Well, but he has decreased intake.
Decreased intake, yeah.
Now this is one case. So there's always a debate about whether you should give lactated ringers or whether you should give saline. Much more debate than ever in my career. I mean, for 38 years, all I ever gave was saline, and I was wrong. And there's a wonderful, for those of you who like podcasts, that if you haven't listened to the Curious Clinicians, they did a wonderful thing on this recently. But I would give saline because in this situation, chloride is important. And that may fix his lactic acidosis, we don't know. Do we have a differential in the white count?
Yes, we do. So neutrophils are 65%, lymphs are 32%.
Okay, so we've probably put HIV to bed.
Oh, sorry, his HIV was negative.
Yeah, no, but that put it to bed because his CD4 count. I mean, even if he had HIV, he'd have a normal CD4 count. Now, what are we gonna do about this MCV of 117? Why do people get MCVs of 117?
That's The sort of classic things that I know of is folate and B12, and B12 is a much longer term problem, and folate's a shorter term problem, like months versus years for folate versus B12.
Okay. But there's another one that we have to think about, particularly in this guy, who's having, maybe part of his shortness of breath is his anemia. And once we give him volume, his hemoglobins are really going to be down to 5 or 6. If he's really volume contracted, starting out at hemoglobin 7.8 after we give him 2 or 3 liters of saline, we're going to dilute it back down. But there's another thing that will cause a very high MCV that we have to think about, because why did all of a sudden he get sick?
Reticulocytosis from something?
Exactly. So getting a retic count is going to be helpful. Now, Jory May would tell you that you always get a retic count. That's how she starts out every anemia workup. I bet that's the way I was taught too. I've gotten pushback from residents before and from colleagues for that. But now that Jory has said it, I know it's true because she's a whole lot smarter about this than me. Do we have a retic count?
Yeah, it was 3.8%.
3.8%. So now we're going to have to do a reticulocyte index. I didn't think we were going here tonight. Does anybody have MD Calc up and can quickly calculate a reticulocyte index for us? And is this appropriate reticulocytes or inappropriate reticulocytes?
I calculated as inappropriate.
Inappropriate.
As low.
Okay. So now we're going to assume that we have to work up, and folate is really rare, so we'd have to think about B12 really seriously. But that still doesn't explain what's going on with all these crackles in the lung. So we really do need a picture of the lungs, don't we?
All right, great. Yeah, so we got a picture of his lungs, which showed diffuse interstitial edema with no cardiomegaly. Otherwise unremarkable.
Diffuse interstitial edema. So where are we going now? So I'll just throw out that maybe that has something to do with the phosphate, but probably not. This is probably a lung disease. The urinalysis means that it's probably not a pulmonary renal. This is post-COVID, Fernand.
Right. Post-COVID or pre-COVID?
Pre-COVID. This is pre-COVID.
I think you gave me the idea, but when I think of diffuse interstitial edema and shortness of breath with an A gradient this high, PJP comes to mind.
Right, but the PJP would be pretty rare in someone who has functioning lymphocytes. Somebody in the chat said something about beriberi. One of our great interns said something about what the hell is beriberi?
Yeah, I totally don't know. This is
I think that's when you have like thiamine deficiency.
So we've been assuming thiamine deficiency.
Mm-hmm.
So, and this would be wet beriberi, right? So that would be a possibility. Now this patient's going to get industrial strength thiamine. As soon as you see these labs, you're not going to give them a banana bag of thiamine because banana bags have very small amounts of thiamine. I don't even know why we give banana bags. But we're gonna go to UpToDate or some other thing and say, how much thiamine can we give? And we're gonna give big doses of thiamine.
Yeah, I do.
We can send off a thiamine level, but thiamine will explain almost everything going on.
When I think of wet beriberi, I think about like the heart failure state. But how do we reconcile that with like the lack of lower extremity edema and
great question.
Lack of like a kidney process, because I think about like
yeah,
the cardiorenal syndrome.
So I'll tell you how I think about it, and then I'll ask the chiefs to chime in. pure left-sided heart failure does not give you peripheral edema. So if all you have is left-sided heart failure, whether it's HFrEF or HFpEF, did I say that right? I'm trying to get the lingo down. Okay, so if it's systolic dysfunction or diet or whatever HFpEF is, I don't even know if it really exists. It just drives me crazy. But systolic dysfunction, at first it just gives you pulmonary edema, orthopnea, and it doesn't give you peripheral edema until you've been hypoxic long enough or you've injured the right ventricle. But it's usually with pulmonary hypertension. And then when you get pulmonary hypertension, you get right-sided heart failure. So while a lot of people with left-sided heart failure end up with right-sided heart failure, they don't all have right-sided heart failure. So I'm perfectly happy early on diagnosing a left-sided heart failure just from the physical exam. Now, we're not going to have a JVD. All we're going to have is our physical exam to go. Now, I would go back to him and find out, has he had orthopnea? Has he had paroxysmal nocturnal dyspnea? And see if that's useful. Did you go back and ask him that, Stephen?
Yeah, and he's had those symptoms for about the same time course.
Okay, so let's be very careful to define what paroxysmal nocturnal dyspnea is. This actually came up in a clinical problem solvers case recently that I commented on the next day. And this is a mistake that most medical students and interns and many residents make. Paroxysmal nocturnal dyspnea, you need two things. You need to wake up in the middle of the night and then have to be upright for at least a half an hour before you can lie back down. Waking up in the middle of the night, short of breath, is not paroxysmal nocturnal dyspnea if you can lie right back down. That's obstructive sleep apnea, COPD, restrictive lung disease. We'll all do that. So just for, especially since we have quite a few fourth-year students on and quite a few interns on, make sure that you ask that question in the right way. And I assume Stephen did. So now we're thinking of left-sided heart failure. Could Diamine explain everything? That would be very, very nice if we could wrap this all up with Occam's razor. We'll order a Diamine level. I hope we ordered it before we gave Diamine, that we thought of it, but we might not have. It's so much easier to do all this when someone presents it to you than during the fog of war when you're admitting the patient. Everybody's familiar with the concept of the fog of war. When bullets are flying, you don't think quite as well. So we're in a very safe environment for thinking right now. If this is all left-sided heart failure, so one possibility is that it's Diamine. He doesn't have a large heart. We'll go ahead and get an echo because it seems like he has left-sided heart failure, and see if anything shows up there. We'll go ahead and try to replete things. Now it's going to be tricky. How tricky is it to try to treat his left-sided heart failure when he's also volume contracted, intravascularly volume contracted? And that's going to be the trick part. And he may have to go to the unit in order to figure this out, because we're going to be balancing different things. So I'm probably giving him saline and Lasix. Saline, the chloride, to try to fix the metabolic alkalosis. I'm going to give him phosphate. And the phosphate, I don't know that 1.3 is hurting his myocardial function, but I think it probably is. And I think the hypomagnesemia probably is, and the hypokalemia. So I think that that whole picture. Now, I have no idea why he got thiamine deficient, if he's thiamine deficient, because we don't have any particular history of why he should get thiamine deficient. The other possibility is he has heart failure, then he got fatigued, and then he stopped eating well, and he got thiamine deficiency for that. So we're not 100% sure about the thiamine, but we are sure that we have to replete things and try to treat what we think is pulmonary edema right now while we're getting an echo and something like that. So Sean and Steve, yeah, go ahead. Josh, you're doing great.
Just for thinking about 9 months from now, when I might be seeing this in the middle of the night, Would you?
when you will be seeing this in the middle of the night?
My first instinct would be like to give him some K-Phos and have him drink it instead of putting it through the IV, because my understanding from just chasing electrolytes for the past month has been these things are really slow infusions over like 4 hours.
Correct.
If that's a practical consideration.
Yeah, I would do both. I would do both. You can't give if you're not in the unit, you don't want to give potassium any more than 5 milliequivalents per hour. In the unit with a large bore needle, you can go up to 10. That's in adults. And what you can do in kids, I have no clue. And I'm not going to give you any advice about kids whatsoever, except maybe their sore throats. So let's Stephen and Sean, do you have anything to add, or do you want to tell us what happened next?
No,
Is there any
I think,
history? Oh, sorry.
no, go ahead. What was your
I was
question?
just wondering if he had any like history of GI complaints or like excessive vomiting or like surgeries.
Yeah, no GI surgeries. For the past several months, he's had poor appetite, but no other GI symptoms. He's not throwing up, no blood in his stool, and so forth. I think that was all great. I just wanted to point out someone in the chat had brought up something called Ziev syndrome. I hope I'm saying that right.
Zieves.
Which is Ziev. Okay, perfect.
Yeah, because actually Ziev's son was on the faculty at MCV when I was there.
Interesting.
Yeah, so I knew Ziev's son.
So Ziev syndrome is an interesting thought. It's essentially hemolytic anemia that arises in the setting of alcohol withdrawal. I will say his T-belly was actually normal, so he was not hemolyzing. But it was a great thought and one that we
right. And if he was hemolyzing, he should have a higher reticulocyte count.
Mm-hmm.
Reticulocyte index. That's why we did the reticulocyte index.
And so I'll sort of walk through what we did. So we got an echo, like you guys said. We gave him IV thiamine up front and checked in thiamine level before we gave that. So his echo showed a normal EF, greater than 55%, no diastolic dysfunction or wall motion abnormalities. He had a normal RV function, but it was hyperdynamic. His atria were normal size, no pericardial effusion, no significant valvular disease. So as far as his anemia, his B12 was in the 700s and his folate was 2. We talked a lot more with his wife, who told us that he was actually drinking far more than he let on.
Really?
He was drinking.
Really? What a surprise.
He was drinking at least a 12-pack a day.
Good.
And so when we gave him IV thiamine and gave him Lasix and a little bit of fluid, he diuresed nicely. His oxygen requirement resolved. His lactic acid actually resolved within hours of giving thiamine, which I thought was fascinating. We put him on a multivitamin and counseled him on alcohol cessation. He did well. He was able to discharge and hasn't been back since.
So Berry's high output failure, right?
Yeah.
Teach us about that, because I always forget about Berry. And somebody in the chat, I think Nisha is the one who mentioned it. And when I saw that, I said, "Damn, I should have remembered that."
Yeah. So ultimately, we diagnosed him with wet berry, which is essentially cardiac failure due to thiamine deficiency. So what you'll have is a normal EF, but a clinical syndrome of congestive heart failure, and it should resolve with diuresis and repletion of the vitamin. The mechanism is a bit unclear. There's a lot of suggestions, so I won't go into it too much, but it is clinically a true entity. And that was what we diagnosed him with, and he got better.
So, love to have the chat participate. I'm going to get Gurleen and Josh and Stephen and Sean to each volunteer the two most important things that they got out of this discussion today. I think, first of all, let's all give a high five to Gurleen and Josh for really doing a great job. We certainly hope they're our interns next year, because we know they do great. And if you're at another institution, try to recruit them. So Gurleen, what are your two big take homes?
I think my number one take home is always the history is super important in any case. So it's super important to double check the history with the patient and kind of ask questions about things that you're worried about, because it looks like in this case, further history taking definitely helped kind of guide the diagnosis and the case. And I guess my second thing is that Diamine is to like keep that in my mind whenever I'm seeing like low other electrolytes and other things, because it can easily be corrected. And I like definitely, I guess I've read about wet beriberi, I've learned about it, but it was definitely like not in my radar. So I think it was really helpful to kind of see a real case about it and see how I can think about it in the future.
Josh.
Whew. So I think my big like personal reflection is to just be a little bit more systematic about looking at the BMP to make sure that I'm hitting all the points. My two learning points were like the pure left-sided heart failure will not cause lower extremity edema, something helpful to remember, at least in the short term. And then urine chloride for metabolic alkalosis.
So Stephen, what were your big take homes?
Yeah, this case reinforced to me that reticulocyte index is a great starting point for anemia. Dr. May taught us that about a month ago, and I've slowly let that creep into my practice. And then there's great formulas for AA gradient on MD Calc, but you don't always need them. If you are on oxygen and have a low PO2, you've already diagnosed a low AA gradient.
Sean, there was no rheumatology here.
No, but I think I can pull something out. So for me, the low FOS, I think the low hanging fruit is thinking about the muscles, but also remembering how it affects your hematologic system with like a decreased function of your white blood cells, and it can cause hemolysis. And then the other thing that I think is easy to think about when we're in the ICU is thinking about how CO2 is a reflection of ventilation. But when people are breathing on their own, we don't always think about CO2 in that term. We just think about it as, is it low or high, but rather correcting it to, are they hypoventilating or hyperventilating, I think can be helpful when you're approaching this.
So, and I've been looking at the chat, and one of the things that several people said is, and Fernand said this, and I'll just quote him: have a low threshold for empiric thiamine supplementation, and you just can't go wrong with that. And it's not just alcoholics. In retrospect, to me, when I saw these labs, my initial thing was, this is alcohol. And then I didn't stick with it long enough, although I worried about thiamine also as we were going through it. So I think that's an instinct from seeing a lot of alcoholics get admitted. I'm actually surprised that his BUN was 10, because usually when you see these numbers, you're going to have a BUN less than 5. I don't know if it went down after you gave him both saline and Lasix, but I hope everybody had a good time. And next week is going to be, once again, you get called by the lab on night float. And then the following week, I think, is the following week liver disease? Or 2 weeks from the following week is liver disease. And then we have an incredible case. One of our nephrologists, Ashita Talwani, who everybody at UAB knows is just a superstar. She won the Narins Award from the American Society of Nephrology as the best clinical teacher in the country. And we're going to present her a very abnormal BMP with some kidney situations. And that'll be, I think, the last week. Is that the last Tuesday in September?
I believe so.
I believe so. We have a lot of good stuff coming up. We really appreciate everybody signing in and joining us. And once again, Gurleen and Josh, y'all were both brave and excellent.
Yeah, thank you, everyone. That was great.
you.
Thank you guys for coming. We'll see you next time.